Good morning, everybody, and welcome to Meeting the Challenges of Diabetes, the Core Basics. And my name is Sheila Heskin, and I am from the Medica Health Plan. And this training is presented to you as a collaborative of health plans. And if you can advance to the next slide. There we go. So this training is presented to you by a collaborative of health plans, and that includes all of the health plans on this slide. And we are, let me just get to my notes here. There we go. We're working together to reduce the healthcare disparities on the topic of diabetes. And late in 2020, DHS collaborated with the health plans to establish this as a priority project in the form of a performance improvement plan, otherwise known as a PIP. And while all the plans, definitely we all had projects already with the topic of diabetes, as we know it's such an important topic with our membership, having it as a PIP really allows us to collaborate together on multiple initiatives and to address the diabetes crisis and to formalize this work and make sure that the interventions are implemented statewide. So it really allows us to really put our minds and heads and our health plans together to do something bigger than just what we do as an individual health plan. And this includes what we're doing today, which is a series of diabetes trainings for care coordinators and case managers. And we know that you're boots on the ground with our membership. And so we have developed what will be an ongoing training series for you that will take place over the next 3 years, beginning today. Today is our kickoff of what will be a 3-year performance improvement project tied to bettering and reducing the disparity between the diabetes care in our membership for specifically MSHO and our SNBC members.
Hey, Sheila, I've had a couple of requests for you to speak a little bit louder.
Okay. Yeah, that's that audio thing. All right, so I will try to speak louder. Okay, the next slide. So what this slide is just a snapshot of what we know about the healthcare disparities when we talk about diabetes in Minnesota. And what we know is that diabetes is the 6th leading cause of death in Minnesota and the leading cause of blindness, kidney failure, and lower limb amputations. And 2 of the measures that we're looking at are the 2019 Minnesota Community Measurement Healthcare Disparities Report, that's a mouthful, which highlighted 2 key findings, and that being that American Indian, Alaskan Native, and Black African American members with diabetes have the lowest rates of A1C control. The second one is that Black African American Hispanic members who have diabetes have significantly lower rates of blood pressure control compared to the statewide average. So these are things that we know about, and these are things that we need to do better on. And as we look at disparities, we look at things like race and ethnicity, but it also includes things like gender, sexual identity, age, disability, socioeconomic status, and geographic location that all can contribute to how people are getting health care and able to manage their health care on an equal basis to other people in other groups. Slide is basically be talking about our future. The MCO Diabetes PIP Collaborative. We meet twice monthly, and we work on devising strategies that help us meet our objectives for the project. So what we clearly recognize is the importance of the work of care coordinators and case managers as it relates to being part of that care team for MSHO and SNDC members specifically. And so we want to prioritize ensuring that you have the resources and tools needed to best help the members and in terms of managing their diabetes. So in future webinars, and as I said, this is a kickoff and the first of what will be several webinars for care coordinators over the course of the next 3 years, which is the duration of this diabetes project. In future webinars, we want to tackle the things that are most you and that what you're experiencing. So webinar, please watch for an email that will contain a link to an evaluation. And in that evaluation, there's a place that we want to gather your ideas and feedback to us about ideas and about your work with members. Additionally, once you complete the evaluation, you will automatically receive a certificate of participation for today's webinar. And during the webinar, we ask that you any questions in the chat box be addressed aloud. Okay, so upward, slide and introduce our presenter for today to do that, and hopefully Dr. Nelson's connection will be better than what I'm seeing in the chat box that my connection is. So Dr. Jody Nelson is our presenter today. He's the lead medical director for utilization management. Dr. Nelson was born and raised in South Minneapolis, attended college and medical school at the University of Minnesota, and went on to complete her residency at Hennepin County Medical Center in emergency medicine. For 15 years, she was an emergency medicine physician at Park Nicollet Methodist Hospital in St. Louis Park, and then an urgent care physician for Park Nicollet. She's been with Medica as a medical director in utilization management since 2017 and is currently the lead medical director of Dr. Jody has a passion for educating on medical topics, and I know today is excited about presenting to you on diabetes. So I'm going to turn it over to Dr. Jody, and I believe you're going to share your screen, and hopefully your audio is good. And I'm going to turn it over to you. Thank you, Jody.
Thank you. I am excited to talk to you today because I enjoy talking to people. I would enjoy much more being there with you, being able to see your faces, discuss things with you guys, and that's really my favorite way to educate people. So the other thing is, I'm really not planning on teaching you everything you need to know to take care of a patient with diabetes, because I know that you know the things. You've been working with patients with diabetes, many of you for a really long time. And so what I hope today is to give a different perspective and maybe to open up ideas on, maybe that difficult member that you have that things just aren't working. Well, maybe I can help you have a different perspective of how it may help to approach things. I also didn't, I should have had it added to my bio. I also have a degree in Native American Studies from the University of Minnesota. So and my senior project was on diabetes in Native Americans. So I do have a lot of experience and real world experience with treating diabetes in Minnesota. It's a topic I'm enthusiastic about, and I hope I can maybe bring some of that enthusiasm to you as well. So, my slides are not advancing. Let's see. Well, there we go. Okay, so today what are we going to do? We're going to talk about the stigma of diabetes. That's a big problem, and it's a big problem in the barrier between caregiver or people in the healthcare profession and patients. It really does create a barrier, and I'm going to try to explain how we can get around that barrier in different ways. We're going to talk about the complexity of the care of someone taking care of themselves with diabetes. We're going to talk about a lot more of the kind of statistics that are specific to Minnesota. And then we're going to talk about how can we deliver effective intervention or just assistance to members with diabetes. So, and that definitely really needs to include an individualized approach. That's going to be one of my main messages. And it also needs to include cultural specific issues and how to sort of approach those. And then we'll talk about recognizing red flags just a little bit. So this is a bit of a trick question, but I'm going to ask you just in a couple seconds what you think of as your typical diabetes patient or diabetic patient, and just have that picture in your head, your typical one. Okay. Now, first thing I want to point out here is we want to try not to call them a patient first, and they are with diabetes. So all of this goes into our way that we think about people. And so I use this phrase specifically because I wanted to point out that they're really a patient. They're a patient with diabetes, and most of the time with a lot of other problems. And I also want you to realize that what we see of patients with diabetes are really the most complicated people that are out there. And they are really challenging to work with. But when you come into each interaction, you have to remember that some people aren't your typical, they're not the sickest ones that are doing the worst with their control. Some people actually know what they're doing. And so we really have to individualize. So with that in your mind of your typical diabetic patient that you work with, what some people's mind comes to is things like this. Here's your diabetic patients. Oh, they can't eat sugar. They kind of think they're overweight, unhealthy. And yes, those are risk factors for type 2 diabetes. But I want to point out there's a whole world of diabetics out there. Okay. And so diabetics are also like this, people out there using technology. Joe Jonas, or no, not Joe. I don't remember. It's one of those Jonases, is diabetic. Who else has diabetes? This is a camp full of kids with diabetes. And I have to tell you, a lot of my perspective comes from working at summer camp with diabetic kids for many years as a counselor and then as a provider as well. And all these kids have diabetes, right? But it's not what we think of as our typical diabetic. So what I'm trying to do is get you just to think that diabetes is just a thing that people have. We happen to treat a lot of unhealthy people with diabetes, but that doesn't mean that that's what diabetes is. This is Jay Cutler, who is some kind of football star on, I think, the Chicago Bears. He has diabetes. Tom Hanks is diabetic, okay? Halle Berry is also diabetic. So I'm just trying to get you to think past, what we see every day, which is those sick people who maybe, has a severe chronic wound, maybe has, their whole world is difficult because of their care of their own diabetes. But what I want to show you is that diabetes shouldn't define people. And sometimes we put people in that box. And so thinking of them as people first, people with diabetes is my point here. We have one more page of people with diabetes. Got Brett Michaels from Poison, Sonia Sotomayor, Supreme Court Justice, Johnny Cash, all diabetics, okay? So my point is there's a lot of things that we have in our mind because of our experience in healthcare around diabetes. And just remember that this stigma it's sometimes, especially when we're tired and we're seeing the same people day after day, the stigma really gets to us. And the stigma of diabetes, we just have to get around because that's what the barrier is between us and providing good care. So the definition of stigma is a mark of disgrace associated with a particular circumstance, quality, or person. And these are other similar words for it. And I would like to say that this isn't the secret, okay? And I hope maybe it'll sort of like change maybe the way you think or interact with a couple patients, maybe. But remember that actually almost every patient with diabetes feels this somewhere in their life. And frequently it's from the people like us who care for them in the healthcare system. So let's talk about that a little bit. All right, here's my point. Everybody knows how to be healthy, right? Your doctor tells you, you eat right, you exercise, you have a healthy weight, okay? And we all feel a little guilty about that when we don't do those things right? We all feel a little guilty. Now, diabetics hear the same thing from their doctors and the nurses and their care coordinators. Then they also hear, take your medications correctly.
Yeah, it looks like Dr. Nelson's audio just went out. Looks like she's trying to call back in. One moment, folks.
Okay.
There she is.
Can you hear me?
Yes.
I have no idea what happened, but I switched over to my computer audio. So hopefully it'll go smoothly now. All right. Let me know if this is cutting in and out and I can call back in on my phone.
Sounds great.
Okay, good. So now we have these things that everybody knows. And then for diabetics, you add on top, take your medications correctly, on time, don't forget them. Keep your blood sugar under good control is what they hear all the time. And keep records of your blood sugars, right? They tell you to do all these things and diabetics understand that's how you're a good diabetic. You do all those things. You lose weight, you eat healthy, you exercise, you take your medications, you keep your blood glucose under good control, and you keep records. Now, if you think, every human being deals with the top three and feels guilty here and there with with when they don't do that. Now you add all these other requirements on, and most diabetics end up feeling guilty about not taking care of themselves as best that they could. And then we come in and remind them of that. Everybody tries to follow a healthy lifestyle, right? We all know we should eat like this. we should do this. We should exercise every day. We all know this. We set up, plans to diet and exercise. It's your New Year's resolution. You're going to do this. You're going to be super healthy. You're going to stick to this plan of eating, whether it's Weight Watchers this year or, you're the low carb Atkins diet, whatever you're going to do. You're going to stick to it. You're going to exercise. And that works out perfectly for everybody, right? No. What we find most of the time, this is for normal people, diabetic or not, that most of these big plans end in disappointment. I want you to think about one of those times when you promised yourself you're going to eat so healthy. Did it work for the rest of your life? No. These people with diabetes know they need to do it every day. You need to support the best they can do, not the ideal, which is a super healthy plan, getting perfect blood glucoses. So support them where they are. Any improvement you make will help them. Okay? One of the things I'm going to just mention here before we go on is diabetes is a huge spectrum of disease. One thing we know is that when we talk about control of diabetes or good blood sugars, the number one thing that is a problem is if you don't find out that there's a high blood sugar and you don't treat it. So what should our goal be? Should our goal be to have our patients have the best blood sugars? I argue that it's not. Our goal should be to have your patient testing their blood sugar so you know what it is, so that their doctor or treating provider can change their medications to get a better outcome. The people who have been disappointed the most, have the most difficulty with labile blood sugars, feel the most ashamed about their blood sugars, and they don't want to check. So if they hand you a sheet full of blood sugars that said they were 240, 400, whatever, all you have to say is, wow, you checked your blood sugar a lot. This is awesome. We can use this to get your medication better, to get you better control. Okay? So it's one of the things that I learned at diabetes camp. If you have, and literally, so as a provider, we would round on the different cabins before breakfast and before dinner, and we'd help decide what dose of insulin they should take. What I learned very carefully there is the kids with the high blood sugars, and many times it would be the same ones over and over, but really you'd see it in all of them. When they had a high blood sugar, they were reluctant. They stayed back to the back of the group, dragged their feet as they came up, because they had to tell you out loud in front of all their friends that their blood sugar was 240. And that is really hard and disappointing to them and humiliating. And so I started saying to myself and all the other providers there, it's just a number. Write it down. We treat it. And when we treat it, that's when you bring down the A1C, when you make people better. So I always worked on encouraging those kids that it's just a number. You probably are not feeling great right now. Let's try and get that better. So the next point is, in barriers to care, diabetes self-care is super complicated. So in some ways, we have to make it more simple for people. They may not, there's some people who are very capable of using an integrated computer system to monitor their blood sugar at the same time as an insulin pump that can do this and that. Then there's lots of people who your goal for them is going to be to take your pill today. Okay, we have to meet people where they are, and anything we can do to improve one little step is going to be great for that person. Okay, It's complicated. There's pills, there's injections, there's multiple pills, there's multiple injections, there's sliding scales. And then there's checking their blood sugar, keeping their records. It's really complicated to be diabetic. And then you throw in eating healthy, exercising. It's a huge, huge, it's very complicated, lots of working pieces for members. To keep my eye on the time just to know that I hopefully can't run over on this time, but hopefully you guys are enjoying this too. So diabetes care is complicated for providers, physicians, down to, anybody who interacts with a patient with diabetes. It's really complicated to figure out. We're never going to understand everything going on with the member. But it's also a very complex disease. It's not the same for every patient. Okay, so this is I'm not going to teach you microbiology. Okay, this is simply for a point. This is a cell wall, right? Human cells require glucose to work. Insulin works at a receptor to help it accept insulin into the cell, or to help it accept glucose into the cell to drive all the intracellular stuff. So there's type 1 diabetes, which is lack of insulin. Okay, so the pancreas stops producing insulin. This is most often comes on in childhood, and it can be, treated with insulin. In general, it's a little easier to control if you stay on top of things with medication. Then there's type 2 diabetes. Now, like I said, the cell needs the glucose to work, right? To do all the things that it needs to do. So here's all the things that insulin and glucose affects in the cell. All right. All of these biochemical pathways. Now, memorize this. There's a test later. Just kidding. The point here is there are so many little spots that can go wrong. And these are what create what's called insulin resistance. And that is type 2 diabetes. So type 2 diabetes, which is more often an adult onset disease, it means that the insulin doesn't work as well as it used to, but it's still there. So it could be in any one of these pathways, which means every single patient with type 2 diabetes has a bit of a different disease than another one. So it may be just the receptor where the glucose comes in that is affected. It may be this pathway. It may be this thing in this pathway or this thing in this pathway. There's no way for us to know, but these are the targets of all of those oral pills, etc. An insulin injection is pretty simple. It replaces the insulin that's missing. Or it supplements the amount of insulin that a patient needs to get the glucose into their cells. But the type 2 diabetes is much more complicated. And now I'm going to just throw out there that actually about 1 in 10 adults has diabetes over the age of 35, just in general. So about 1 in 10 type 1 diabetics develop type 2 diabetes, meaning that their cells become resistant to the insulin that they take. So it's very frequently a combination, and people who've had type 1 diabetes their whole lives, as they grow up, may become insulin resistant, making their disease much more difficult to manage, and making their medications much more difficult as well. This is just to illustrate how complicated diabetes care is. This is the American Diabetes Association recommendation for medications. Okay, so it's a stepwise therapy. And when you get down here to triple therapy, it's so complicated. So you start, the first line is almost always metformin or glucophage. It's just a pill twice a day for, this is for type 2 now, just for insulin resistance. And it has a lower side effect rate. It's most commonly used. So then the next thing would be to add the metformin and add one of these other things. And then once you have one of these other things added to that and it's not working, then you go on to the third. So if you chose this one up here as second therapy, you go to this list and these are the other ones you can try. It's very, very complicated, very complicated. And so I don't think I could ever hope to understand diabetes management completely. There are so many different things, and you can see they work on all those little pathways that we saw in the cell, and so in different places. So it's very, very complex. How can we help? Well, we need to just slow down. Okay, so we need to start by understanding the issues with the members. Okay, what is unique to their community? What's unique to the individual member? Okay, so we're going to start more at a more local level. And we're going to talk about the diabetes in Minnesota. Okay, so it's not good news that this is the percent of adults that has diabetes. And the darker lines are Minnesota and the lighter lines are the US. So we're doing better. But as you can see, from 1996 to 2019, it's really gone up every year. Okay. So that's not great news, but we're better than other places. The other disappointing thing is this, the study that they did in Minnesota found that income and employment is really directly related to the incidence of diabetes. So in adults in Minnesota, when the households earn less than $35,000 a year, they're 2.5 times more likely to have diabetes. And 1 in 4 adults in Minnesota has an income below $35,000. So there is a link on here that you can go to look more at statistics. We also know, so these are Minnesota statistics in terms of what percentage of a population has type 2 diabetes. Overall in the US, in Native Americans, it's 17%. In Minnesota, it's 25%. So this, of course, is an area where we need to focus. And it is very interesting that the incidence in different populations of Native Americans across the US is vastly different. But it is usually all higher than the general population. Oh, so if we look back, let me go back one slide. Right here we see that about in 2019, about 9% of people in Minnesota adults have diabetes. Okay, so if we keep that as in the back of our mind, 9%, we can kind of look here. Diabetes in Asian Americans in Minnesota is fairly low compared to the US. Even in African American populations, we're less than the US average. Hispanic, we get closer to the US average. And, let's see, sorry. And then when we get down to Caucasian, white, we are also, nearing 9%, but we're less than the US average, which is 10.7%. Okay, our incidence of diabetes is really directly related to the level of education for type 2 diabetes. So in Minnesota, you get up to 15.4% if they've had less than a high school education. If they're a high school graduate, it goes down to 11%. If they've had a little bit of college, still fairly similar to a high school grad. And if they're a college grad, it goes down to nearly half. Now, you heard at the beginning of this about, how we need to improve those measures for diabetes care, and we have to worry because the complications are, people losing their eyes, their legs, their kidneys. It's terrible. And I want to just give you some good news here. First of all, I highly recommend not talking very much about those things to people with diabetes. It's one of the big gaps that we have with them. They know that they could lose their legs, lose their kidneys, go blind. They've seen their cousin go through it. They've seen their parent go through it. Everybody knows how unhealthy it could be. But let's give credit to what we're doing right. We have the science now to know exactly what we need to do. There are things we can focus on, okay? And we're actually doing a good job, and we have to continue to do that, okay? So what are we doing well? These are the measures that we look at for diabetes care. And in Minnesota, we are doing pretty well. You know, patients with diabetes have these goals that we look at for optimal care. And if we look overall, we measure that 88% are getting their statin in to control their cholesterol. 83% are getting the good blood pressure control. Daily aspirin use, 99%. Blood sugar control, 69%. That's pretty good, okay? And no tobacco use, we're up to 84%. These are the things that we can affect. Do you know that there's been studies that even in people who've used tobacco use for their whole life, or hopefully not their whole life, okay, their whole adult life, but even in people who've been a chronic tobacco user, in the ones that quit, most often it's because a healthcare provider said something to them that just rang true that day, and they felt they needed to change. The studies show that. That's what is most likely to change you. Does this mean we should lecture people on their tobacco use every time we see them? No. But it means that what you say might be that one thing that changes it. Try to make it a positive message every time. You know they've been smoking forever. Ask if they've, could you have a goal to cut back? Could you have a goal to cut down? Could we set a stop date for you in the future? And we can talk with your doctor about whether medications might help with that. There's lots of resources out there to refer patients to discuss tobacco cessation. And I know you guys know those kinds of things. But I want you to know that overall, this is good news. We're doing pretty good, okay? Overall, half the patients in Minnesota meet all 5 of these, okay? So that's good news. More good news. Adults with long-term complications, these are the people we're talking about with amputations, heart disease, strokes, chronic wounds. The admission rate over time for people with these long-term complications is going down significantly. From just 2006 to 2014, we've seen a significant decrease. That's because the complications are getting to be less. Okay, the admission rates for uncontrolled diabetes have gone down significantly. If you look here from 2006 to 2014, we're managing to keep people out of the hospital and keep them in better control overall. Better medications have come out. Lots of different things have changed. When we talk about complications of diabetes, it's all about blood vessels. And that's why we want to focus on the cholesterol, getting that just addressed and taking care of, the blood pressure, and then the blood sugar, the blood glucose over time is what's important. How long does the lining of those blood vessels see a high blood sugar is really what determines how bad the damage is going to be. So if you have someone who checks their blood sugar in the morning, finds out it's 240, takes their sliding scale insulin, and then over the next couple hours, they come down to a normal blood sugar, that person has a lot less complications if that's their pattern every day than someone who wakes up and doesn't check their blood sugar because they know it's going to be 240. They do nothing about it. They stay 240 all day. Those are the people who get much worse vascular problems. It's the time amount of time that their blood glucose is high. We want to try to focus on checking so we know when it's high to prevent the vascular problems. All right, so these are the main things that everybody knows, and every diabetic patient with diabetes knows that the complications are non-healing wounds on the extremities, vascular problems like stroke and heart attacks, kidney failure, and blindness. So we've talked about the prevention and management. Get the blood pressure under control, decrease the time with high blood sugars, and watching to minimize low blood sugars. So especially with people taking insulin, you want to make sure they're not being too aggressive, really following the plan, because low blood sugars actually can have immediate damage if it's a very low blood sugar, but actually over time it's shown to cause vascular problems on its own or other problems. And we want to focus also on treating the high cholesterol, decreasing obesity if we can. All right. So this is more good news. Now, this is not even recent. Okay. This is just 1990 to 2010. The good news is we decreased the number of heart attacks in diabetic patients by 68% in 20 years. The death rate due to high blood sugars down 68%. Stroke down 53%. These are real numbers. Amputations down 51%. This is huge. We all think of these terrible situations and are very sick patients, but realize that it's because people have more control over what they can do about diabetes now, that we have significantly reduced all these complications. Less people are losing their legs. Okay, this is really important. We've done this, and it continues to improve, as you saw from my graph that I showed you earlier, that all of these long-term complications are decreasing. As a matter of fact, type 1 diabetics now who are initiated on the correct insulin therapies have almost a normal risk of getting these complications because they have the ability to control their diabetes so much better than we used to. So what's not going so well? This is about all kids. This is a prediction from, I meant to tell you that most of my slides have a little thing in the corner that says where the statistic comes from. This one is from the Minnesota Department of Health. It predicts that this is talking about obesity, and it predicts people who are 2 years old right now, what's their chance of obesity when they get to age 35? 59%. 59% of today's 2-year-olds will have obesity when they're 35, based on the way trends are going now. Okay, so let's stay positive. That was the one thing that I wanted to show you that we can hopefully influence, but again, with positive messaging. Okay, so how can we deliver effective care? You know, during this study of the Minnesota diabetes care, I actually participated in this planning program for the next level of the Minnesota Department of Health guidelines for diabetes care. It's called Diabetes and Cardiovascular Disease 2030 plan. And they went out and they asked a lot of the people out there caring for people with diabetes, and it was people in the communities. And so it may have actually been you that they asked. And if this is you who your quote is on there, thank you. Okay, but here's the quotes that I saw when I got to look over all these comments that people made. But I really loved this. And it was that we just need to reframe the mindset of, we have all the answers, you have to change. What we have to do is say, why don't we change our behavior to empower the patient to change their behavior? Sometimes the thought of this is exhausting. I get it. But anything we can do to positively positively affect a member to be healthy is great. Okay. So it also hear the statement that we need to change our mindset, that the patients are wrong or broken, and only we have the answer to fix them. We need diversity and engagement, design and solutions. But that's, you know, of course, that's a system-wide thing, but it's also within yourself. Okay, the more positive care you can give, the better outcomes we'll have. And little changes are what matter. And we all have the power to do that. But we all also get exhausted with caring for people day in and day out. And sometimes it's just very exhausting to try and re-energize as to how we can positively interact with a patient. So how can we do that? First of all, look at your patient. Start with that patient. Get to know them. But here, if you have a patient in front of you who looks like he has maybe a little visual impairment, he looks like he has no idea what those pills are and is sad. He looks sad. This is a patient where you're going to talk about trying to encourage him. You know, you're going to talk about, well, what are the challenges for you in learning how to take these pills? How can I help you? And really get into, for this guy, what is making him upset right now? Is it that his doctor told him if he doesn't lose weight, he's going to die? Maybe. And that's a scary thing to talk about. And I would encourage you to address that by saying it's the little things you can change. You know, even if it's one day out of the week that you eat healthier, that's a great change. Think of that over a year, how many days of healthy eating you had. Okay. So addressing really what the individual is experiencing. Start by asking, okay? A lot of these people have more experience with diabetes than we do, okay? So ask them what they know about their diabetes. Ask them what they want to know about their diabetes. Find out where they are. You may have a guy like this who's, you know, been told you have to exercise, you have to eat this, that, you have to take these pills exactly on time. Find out how you can help them do a little bit more of what would be better for them. Listen, it's really important. We sometimes forget that when we try to tell them how to be better. But listening to an individual patient concerns many times, that's the time that you can have that effect. You find out what's important to this member. Maybe he's just concerned that he can't get to the grocery store to get healthy food. Focus on that with this member. He's going to feel great if you can find a way to get fruits and vegetables into his house that he hadn't thought of. Okay. And that will make a huge difference if it's a long-term change you can make, but even if it's a short-term change you can make. All right. So listen to what's important to the member and support them where they are. So again, we already talked about this, identify their issues. And then it's really important. We all know this who deal with, you know, going to the doctor every year and hearing you should exercise more, you should eat better. You want to make sure that our messaging is positive, that it's not going to sound like you're going to lose your leg if you don't do this, or you're going to go blind, or anything like that. We have to be sure to say, let's just change this one tiny thing and see if you feel better. Let's just write down the blood sugars. Just, you know, if they're not doing any blood sugars, get them to write it down 3 times a week. Okay. You know, whatever small step you can make to encourage people is going to be great. All right. More on how we can deliver effective care. Of course, you guys are really good at this, but identifying barriers, that's it's truly whatever we can do to bring down barriers and encourage people positively. So of course we want to look at things like the food insecurity. Can they get to healthy food? How can we help that? We want to make sure that they have, many times it's a question of, do you have a safe place to exercise? There's a lot of neighborhoods where I wouldn't say go out and walk around the block. But that's really, you have to find out where the member is. If they love to walk around the block, get them doing that more. If they're scared to walk around their block, think about other ideas. Can you go to the mall and walk around? Could you, do some of these exercises in the house, or just little things like that? Get up and get moving more than you have been. And of course, we know there's lots of transportation barriers in getting things that people need and making sure they're in a safe place to take care of themselves. This is all things that you deal with every day. And I couldn't help to educate you on those. But always staying positive in helping to identify what this member's problem that you can help them solve is. Okay, the other thing we want to do is make sure that the care is culturally appropriate. And we can never hope to truly understand each person's culture, because it's not like you can say this person comes from here, therefore they think this way. No such thing. We want to make sure that we understand what they believe, for example, understanding what their family eats, things like this. But so we want to also be careful not to say this culture needs this care, but we need to engage people who are in this member's circle. And so engaging support is so important. And community health advocates is a really, and some of you are this, you are this. But for example, this is posted on the University of, I don't remember which university, but they have this is their health advocates, and they look just like college students. So they're perfect for their university health system, right? Health advocates are hopefully people who have some connection to the community and can really help to bring the pieces together of medical care and whole person care. So I know this isn't new to any of you, but engage as many people as you can. Family, if there's someone there that's supportive, or friends, but community as well. And I know that that all the health insurers are moving towards trying to find ways to help incorporate this. There's some exciting new programs that I've heard of coming to Medica that will engage community in helping support people with many different diseases. I look forward to the next few years to really start figuring out how we can deliver more effective care to people who are in vastly different situations than a standard patient, or just in vastly different backgrounds, and how we can do better with care. I think that it's exciting what's coming down the pipeline. Hearing the diabetes plan for 2030, I'm excited. The goals are great, and a lot of it is about engaging community and support for our members and our patients. So I'm going to move on from this, and we'll talk a little bit about diabetes red flags, because I'm not going to try to educate you on every treatment for diabetes or anything like that. The next slide shows you this is just all the different medications and what the bad side effects can be, what their benefits are, and some of them it talks about how high cost they are. It's impossible to know, is my point, what all the side effects are. Let's talk about some common side effects of medications. So The red flags, one of the most, as I showed you on that list that was so complicated for providers and how they care for diabetes, one of the most common medications used for people with type 2 diabetes or people with type 1 diabetes who now are insulin resistant is metformin, most common first-line treatment. And so most of your patients, unless they didn't tolerate it, will be on this, even if they're on multiple medications, if they have type 2 diabetes. So it's important to know what the side effects of that are, because they really affect people's compliance with medications, but basically their ability to take this long term. So it does cause side effects of stomach upset and diarrhea. Gets better with time, but really a lot of our members are not going to have the patience, right? They get upset and they, experience 2-3 days of this and they are done. They don't want to try any longer. And again, we have to meet them where they are. So of course you want to watch for dehydration. You want to just talk to them about, are you feeling any side effects? Are you feeling dizzy? Are you drinking enough water? Most of the time, the diarrhea is not significant enough to cause people to be dehydrated, but you may have someone whose nutritional status is kind of at risk to start with, and then you give them this that upsets their stomach and they don't want to eat or drink anything. So keep an eye out for that. But the most important thing is, and this I think gets neglected by providers quite a lot, is you have to encourage them that if the effects are too much, most people will just, a lot of people, patients will stop taking it because they don't like the diarrhea and they'll never tell anyone. They don't follow up with their provider. So we need to follow up with that. How's it going? Are you able to take it? What did you feel like? If it didn't work for them, really, really have to facilitate that discussion to get back with the provider who ordered it to see, is there a different medication that would work? Does this need to be started at a different dose? What would the next step be? Because this is one of those at-risk places where people who are less likely to take care of their diabetes are less likely to be successful with initiating a medication here if it gives them side effects that make them feel yucky. So encouraging them, let us know what you feel so that we can address it with your provider is really important. All right. So that's a little bit of a red flag. Now, one thing you have to watch out about is low blood sugars. A lot of the medications that can be started for diabetes can cause low blood sugars. Of course, that's, you had a high blood sugar, we're treating it, now you can have a low blood sugar. There's a few that don't really ever cause low blood sugars, but most of them can cause low blood sugars. And some people might not understand what a low blood sugar is when they're experiencing it. So what might you see? You might see, the most common thing I think is confusion and sweating. Okay, so it's kind of a clammy, pale, sweaty, and then talking different than usual, difficulty speaking, sometimes feeling shaky or hungry, pale. And then if low blood sugar gets low enough, a person can become unresponsive or unconscious or can have a seizure. Watching someone have a seizure is one of the scariest things ever, but realize that it's going to be okay. They are going to be okay. It looks terrible, but it doesn't go on for a very long time usually, and they do get better. Excuse me. And hopefully that doesn't happen in front of you. But recognizing that if you're seeing any of these things, those are people that need to be really checked closely. Either have them check their blood glucose, check it if you have that option, or you can call for an ambulance if you think they might have a low blood sugar. If the ambulance gets there and they're not low or they're all better by then, the ambulance will go away. But they all have the equipment for checking blood sugars and checking in on people. So there's also a very specific, very dangerous problem, which is called hypoglycemia unawareness. Is the adrenaline system, it's the adrenaline system. So adrenaline is, your fight or flight reflex. So, I'm getting a message that my internet connection is unstable. So I hope that you guys can still hear me okay. So this is what you would also experience if there was a bear chasing you, right? You would experience all these symptoms because it's the adrenaline being released. Okay, now some people have hypoglycemia unawareness, which means that their nervous system, sometimes as a complication of diabetes, it doesn't do the same thing when their blood sugar is low. So they don't get any of these symptoms and they don't notice anything until they're in more of a very significant hypoglycemia, like they're having trouble speaking because their brain's not getting enough glucose, or they may be unresponsive. And so there are people who've had, usually it's people who've had diabetes for a long time that may be unaware of their hypoglycemia. If that's the case, these are people that really, really need to be monitored if they don't notice. I mean, every diabetic can have low blood sugars without really knowing it right away, but eventually they get shaky and that kind of stuff. But people who consistently don't get any symptoms from low blood sugar, those are the ones that can be in significant danger. And we'll talk more about technology in a little bit, but these are people who are a perfect candidate for a continuous glucose monitor, because that is really good for knowing when blood sugars are high, but also when people are in danger of low blood sugars. So, sorry, I have things popping up on my screen. Okay, more red flags to talk about. Really things that and again, I know I don't have to teach you or lecture you on this. We have to make sure that patients are able to get their medications. These medications are really expensive. Hopefully that's not a problem. Hopefully the insurance has worked smoothly and figured out with the pharmacy how it's going to be covered and the member gets it. But this is something we have to check on. Can they get to the medication? Can they afford the medication? Is there anything we can do to assist with that? One other red flag issue is people, especially with type 2 diabetes, who've had it for a long time, are at risk for the vascular complications in the feet. So those people who lose their legs, the first thing that usually happens is they get a wound on their foot, and then it gets worse and worse, and they either neglect it or they care for it and it gets worse, and because there's not great circulation, it doesn't heal well. But the biggest thing about this is knowing that the wound is there. The wounds occur because of neuropathy, which is decreased sensation in the legs that can come with long-term diabetes. Okay, so they most often don't feel these wounds. So encourage every member to actually look over their feet when they take off their shoes and socks at night. Have it part of their routine. Okay, if you're someone who's providing care to them, look at their feet. But otherwise, encourage them to look at to have a system of when they check on that, because that is the most important thing, is to catch that ulcer on the foot before it gets worse. Put padding in, identify like what shoes caused this. They usually know which ones it was. Make sure that they're not using those shoes, protecting their foot, whatever they need to do. Make sure that they're wearing socks. And that's actually a focus of one of the things that people who have a much lower income may neglect is actually good socks. If we can find ways to get them cotton tube socks kind of things from Target or whatever, that's what they need. Padding between themselves and shoes to make sure that they're protecting their feet. Because again, that's what's going to progress into losing a limb if it's not taken care of. So if you can get people socks, I did my training at Hennepin County. We used to have a bin of brand new socks, and we'd all throw brand new socks in there, and we'd put them on every person who came in, because they're not every person, okay, but we actually had an area called special care, which was mainly people who were homeless and intoxicated. We would put socks on all of them because they were out and they would frequently have very poor foot care. Anyways, it's very important. Wear socks. Also, red flags is what we talked about, the problems tolerating medicines. Make sure that they feel comfortable speaking up about that you ask, how are you feeling with the new medication, so that you can address the problems that they're having to see if a medication change is needed or what's going on with the member. And another red flag is living alone. So in patients, especially ones who are on medications who can make a low blood sugar, it's a little risky to be alone with no one checking on you. Maybe a good idea just to have that person have someone who checks in on them, especially if they're starting a new medication, check in on them once a day, make sure everything's going okay. I know these are things that you guys work with and think of all the time, but I think just mentioning it is all my intention is here, not to teach you. Red flag. Can you see the markings on this syringe? Most patients can't. Many people have a barrier to taking insulin because they can't see the darn syringes. Okay, either they can't see it because they just simply need reading glasses and don't have them. Maybe that's something you can help them with. Is it because they don't understand or they don't remember? In cases like that, you may be able to do something like make a big card that tells them, here's your sliding scale insulin. And then some people just really don't have the dexterity to do this. There's options, okay? And so we'll talk about a couple options. And now we get to kind of a little more exciting part of the talk, because we're going to talk about technology. There's actually been studies that show that people with diabetes, when they get new technology to take care of their diabetes, many times their control improves. This is especially true with like the younger people who are into technology. Of course, other people may not engage with technology, but the people who are excited about new technology, it actually makes their A1Cs better when they get new technology because they're excited to use it and they'll use it more. So let's talk a little bit about technology. So first thing I'd like to point out, there's lots and lots of different kinds of technologies out there. Insulin pens are specifically really good for people who may have visual impairment. There's many that have sort of magnification here of where you dial up the insulin. So you basically, the pen comes with a cartridge of insulin in it, and then separately these needle tips that you screw on. And that's really kind of the major part of the dexterity. Then what you do is you turn the dial to get the dose of insulin. So, and it goes, some of them go by 1 unit, some of them go by 2. And the thing that almost all of them do is that as you turn that dial, it clicks. So people with visual impairment or even blindness, can count the number of units. And they don't have to try and draw things up with that syringe that they can't see. So this is a really good technology advancement. It's been around for a long time and most people use these. These are even, when people are taking insulin, there's many different kinds of mixes of short and long acting insulin that come in pens like this, so that, you don't have to draw up one, draw up another one. So it's a good technology, been around for many years. Blood glucose meters are getting smaller and smaller. These look really tiny, but they're not. They're like this big is the littlest one here. But they're very easy to use. Some of them have, the considerations are, some of them are easier to read for someone with visual impairment, but most of them have big screens. But obviously you'd want to consider this one would not be ideal for someone with visual impairment because you could barely see compared to the other ones what the glucose is. So make sure that they have a technology that's working for them. Know that these little meters really only cost about $20. So, if this is the one that your visually impaired member has, get a different one so they can actually see what their blood sugar is, because this would be a huge barrier to care in someone with visual impairment. There is also, as we go along the technology, here's Mr. Jonas again. These are continuous glucose monitors. There's different ones on the market, and we'll talk about kind of what they can do. But the first thing is, for anyone, that it can give them a continuous reading of their glucose. You see the number anytime you want to look on your iPhone. These also connect with the insulin pumps we'll talk about later, and it gives a reading there. But it'll show up on your Apple Watch. Mine right now, I could tell what my blood glucose is. And there's some of these are very expensive. They're related to insulin pump systems. And so just trying it out is going to be really expensive to start. This is one that's on the market that's much less expensive for just trying out the first time. With your first package, you get, this is a reader device that's like a meter. You just swipe it over the thing that's the patch on your skin, and it'll give you a reading. Now this reading, you're seeing 12.8. That's actually European. They go in millimoles instead of milligrams per deciliter. So hopefully the blood sugar is not 12.8. That would be a little scary. So these are the common thing with these is that they're small patches on the skin. They usually stay on for 7 to 10 days. And then you need a new one. And they communicate to something else. And then they'll give you, this is what you can see even on your iPhone. You can see these beautiful graphs. This is something that's like showing over time where the blood glucose range is for this person. And then you can see every day, it'll give you so this way you can address patterns like when the highs occur, when lows occur, and adjust the insulin doses. So it's very helpful. But for people who are not aware of low glucoses or have frequent low glucoses, they also have really annoying alarms that do wake you up in the middle of the night. Excuse me. They start out quiet and they get really, really annoyingly loud. So they are ideal for hypoglycemia as well. Next technology that can be really helpful for most type 1 diabetics have this now, and some type 2 diabetics. Insulin pump, there's lots of them. This particular one has a screen that's all touch screen. This one has buttons to enter. They're programmed with things set up by the provider that are like for, per carb, how much insulin you need. So this person, if they wanted to take a bolus of insulin for eating, they would push the bolus, would pull it up. You'd say, I'm eating 45 grams of carbohydrate, and it calculates how much your insulin you need. It also takes into account blood sugar. So the more the sliding scale kind of thing. So if your blood sugar is high, it'll add insulin at the rate that has been calculated by your provider. So they all have those capabilities. So most of them connect like this with tubing, and that part is replaceable. And then some of them are there. This one is unique because it's pretty small and it's disposable. So people need to change it every few days, and they throw away the whole insulin pump because you can't refill it. You can only fill it once. And this one, as you can see, there's no tubes at all because it goes directly into the arm, and you control it on your iPhone or another technology device, where you would, again, enter your glucose, enter your carbs, and it'll give you insulin. These are things that are fantastic technology. Many type 2 diabetics will never get to this level of wanting to manage or needing to if oral medications can control things. But these are the options. And so now you've seen them, you can talk more about them if they might be an option for your patient. Now, the next great step here is what we call closed loop. Now, nobody has a closed loop yet, but what this is it's an insulin pump and a continuous glucose monitor working together. This is very, very common now with insulin pumps. Each one has a different kind of continuous glucose monitor that they work with. And as you can see here, this is the insulin pump in the back. This is the continuous glucose monitor over here that would be on the skin. And this one monitors the blood sugar all the time, the continuous glucose monitor, just like it reads out on your iPhone. It'll read out on your pump here what the blood sugar is. It'll give you the graphs here. You can download this. This one adjusts, I think both of these do, adjust to low blood sugar. So these areas, this is over time, but in these areas, the patient got low and it turns off. So this one, it sees that they're getting low, turns off the basal insulin, which is the insulin that they get all the time, turns it off, and that allows their blood sugar to bounce back. So most of the technology will shut down for low blood sugars now. This particular pump now will adjust for high blood sugars and increase the basal rate, which is that's the next step in technology. This one's getting close to that, I think. They may have it soon, or they might have it already. But the point is, these don't take as much user interaction. Like, you don't have to calculate the sliding scale. It does it completely automatically based on your blood glucose. It's exciting technology. So now that we've kind of gone through and seen all my slides, etc., I know that you guys probably have a lot of questions because I know you deal with a lot of different things, and I'd really like to give a lot of time here for questions. But again, I want to end on a really positive note and kind of just say, let's all work on making diabetes management really a positive experience for members, because that's how we will get over the barriers to a good relationship with our members, with our patients. We have to just focus on not a big picture of you've got to exercise and eat right and do this and do this. We've got to focus on the smaller picture of this week. What can we do? Could you get out and go for a walk twice this week? That's going to be awesome. Whatever you can do to move things a little bit. People feel better when they go out and get walking like that, and are more likely to do it for the future. So whatever we can do to move the needle closer to healthier behavior, it's great. Okay. So remember, you might be the one who gives someone an idea that really sticks in their head, and they're able to really follow through on it and make their diabetes care great. So now I've seen that the texts, the chat messages are coming through. I think that we have plenty of questions.
There was, Jody, can you hear me? This is
Yeah.
Sheila. Okay, so one of the questions that kind of ties to the technologies that you discussed, and how well are they covered with, for example, the SNBC product or the continuous glucose monitoring? Is it covered by Minnesota health plans? So some questions about that, about the coverage
Yes.
for those technologies.
Yes. So the coverage is pretty good. Now, there's lots of different variations, and most of the doctors who are familiar, most often insulin pumps and insulin pumps are most often prescribed by endocrinologists or diabetes nurse specialists, people who have a lot of experience with it. It can help the member choose the right thing. They also have a great deal of experience with insurance, because there's lots of little things, like there's one insurer in town who only covers one brand of insulin pump. Most insurers cover all of them and leave it up to the patient and the doctor to choose. So the insulin pumps, when prescribed by a doctor, are generally covered. I don't know if it requires prior authorization. It doesn't for Medica. I don't believe it does for anyone else, but they're generally covered and pretty well. And the continuous glucose monitors are covered pretty well. There's a little bit of variation for type 2 diabetes and continuous glucose monitor coverage. Most insurers cover it for type 2 diabetics who are on insulin, or I think, frankly, you could argue the medical necessity for any patient who's experiencing low blood sugars should really have that if they're getting in danger with low blood sugars. So you on the continuous glucose monitor, you may have to find out what the coverage is. Medica has changed to covering for type 2 diabetes on insulin. And I think many others are similar. In the past, there was not covering for any type 2, but that's mostly changing. So you'd have to check on that. But usually if a doctor says it's medically necessary, and they will be covered. And it really is a very individualized selection process, to even understand if a member is a good candidate is very complicated. And so someone who has the expertise is the right one, because they have to be able to understand how to fill the cartridges, how they have to, have the dexterity to insert the infusion line, and problem solve if there's a, problem with it. So it requires usually some education ahead of time before you pick it.
Sure. Yeah, and I think, our group has discussed for future training for care coordinators, since there's, we see a lot of questions here with regard to coverage and so on, that something we might do in the future, if it would be helpful for care coordinators, is to do a training on the benefits sets for MSHO and SNBC, and some of the supplemental benefits that each plan offers that are tied to better management of some of the diabetic kind of areas. For example, foot care benefit is enhanced for Medica, and I'm sure there's enhancements like that with other plans as well.
Yeah. I did want to make a point. So I saw a pop-up. I haven't been able to monitor the chat while I've been talking, but I just saw about the more private insurance. You're right. The coverage under private insurance is such a problem because of the high deductible and copay issues. It is very expensive. The high deductible health plans, up front, a member has to pay so much for these before they start getting reimbursement for them. It's really a barrier to care in a lot of situations. Luckily, with our special needs, SNBC, MSHO, the coverage is much better. But still may vary from carrier to carrier a little bit,
Great.
depending on who's administering. Mm-hmm.
So it sounds like there's another question, Jody, that the insulin pen with the insulin pen, how long does the insulin last? Can a person have a couple of them in their home, i.e. can a nurse set up their insulin once a week? Or how does that work?
So the pens come with about, I think, 150 or 100 units of insulin in it. They come in all kinds of mixtures of insulin and then separate insulin. So, there's long-acting insulin, there's short-acting insulin, and then there's the ultra long-acting insulin. People who require insulin management, not just small amounts of sliding scale, usually take one long-acting insulin. They take that once a day, usually sometimes twice a day, but it's usually, taken either at night or in the morning, whenever it's going to work best to remember every day. And that's the background basal insulin. And then when people eat, they would take the other insulin pen that would be the, just the spike for when you eat. So you eat, 45 grams of carbohydrate, you take your sliding scale insulin, they're the short acting. So you may have two different pens. Luckily, they do make them look quite different from brand to brand. And even so there's lots of options. One problem is it's difficult to leave the needle on the insulin pen. It has to be put on each time you use it, because if you leave it on, it leaks insulin the whole time a little bit. It'll drip, drip, drip. And I think insulin smells really bad, but not everyone does. So there's lots of options with those though. There's some people who will have a mixture of short acting and long acting in the pen. If that's the way their doctor sets up the dosing or their provider sets up the dosing. And it's much easier to manage a pre-mixed insulin. You'll see they're called like 75-25 or 70-30, because there's 70% long acting and 30% short acting. So you'll see members who have those. So there's no way to really completely set it up ahead of time. They'd still have to click in the dose and put on the needle tip, but the whole insulin pen is disposable. So when it's empty, they just throw it away. So it's not difficult. You don't have to really refill it or anything like that. There used to be at least some that were not disposable, which is good for the environment, but they're much harder to manage and refill. So most of them are disposable these days.
Okay. There's another question here. What advice would you give for members who have become so accustomed to high blood sugars that they struggle to take their medications as they indicate unwanted symptoms, mostly headaches, of their blood sugars coming down within a normal range? They seem to be well aware of the risks associated with the high sugars. One member in particular is legally blind, not related to diabetes, but just some advice about that member profile, which I'm guessing is not
question.
uncommon.
Yes, it's a great question for two reasons. Okay, the first one is more subtle and not well known, and that is someone who lives with high blood sugars, say their blood sugar is usually above 200, they will feel like a low blood sugar when they get down to a normal blood sugar. So if they come down to 120, they will get all those symptoms that you saw on my list of low blood sugars. They'll feel shaky, sweaty, terrible. Now, that's all because their body's sort of reaccustomed to the level of glucose that it functions with. And so, so acknowledge that yes, you can feel bad when we change that, where your blood sugar is, but that gets better. Don't say that they can't eat when they're 120 and feel all shaky like that, tell them, yeah, just go ahead and, have something to eat. Treat it like a low blood sugar because it feels terrible. You can imagine feeling like what you would feel like if a bear was running at you. You're sitting there shaking and, feeling horrible. Yes, treat it as a low blood sugar just because it feels so bad. And so realize that low blood sugar feeling will happen at a different level. If you have people who are super tight control, they'll run blood sugars of 70 and be comfortable. Now you have someone who lives at 200, they get to 70, they might be unconscious. So there is a huge variation in how people feel. Now, so that's the first part of the question, is that it really actually, there is a big difference in how people feel when they bring their blood sugar down, depending on what their blood sugar usually is. The second part of that question, I think, is a little bit of the diabetes burnout question. So many patients have had experience over time with providers, medical professionals telling them that, they need to do all these things, but not listening when they have trouble doing the thing that you're asking them to. So taking a medication makes them feel sick. That's a great thing to take back to the provider. The provider maybe never asked. They'll just look at the list of medications and say, well, it's still not working, let's add another medication. Well, if they're not taking the medication, it's not going to help. So finding out if that's the problem, can we find a different medicine that's not going to make you feel that way? Or for that person who always runs, 250, 300 blood sugars, can we just see if we could just bring it down a bit? Any improvement you make over time will help all the complications. They've shown clearly each step down you take in the A1C, which is what measures your blood sugar over like about 3 months of time. Each step you can bring that down, the average blood glucose, the less complications you have. It's directly related. And 20, 30 years ago, A1Cs did run much higher because there was less options. People didn't have as much control. When I first started going to diabetes camp, I was 7 years old. We checked urine samples for sugar levels. There was no blood glucose testing devices. Can you imagine a cabin full of 7-year-olds checking how much glucose is in their urine? It's a mess. And it gives you no idea of what the true blood sugar is. I don't know how they did it back then, but there was no control. You didn't feel like you have any control over your day-to-day. And, if that had continued from when I was 7, there'd be a lot of people with a lot worse complications. And so the good news is with technology really does come improvements. And so the burnout factor, though, is a huge thing. And again, those people who run high all the time and don't care, it may not be that they really don't care. It may be that they're tired of talking to providers about it because they get negative feedback. It's really, really, really common to go in and, see someone who's never lived with diabetes, and they'll say, okay, well, what was your blood glucose this morning? Someone says 240. They're like, oh, no, it's just a number. Tell them that whatever we can do to bring it down, they'll feel better. They'll be healthier. Whatever we can do, little thing. Maybe this week they eat more vegetables. Maybe that's it. Maybe this week they take their pill every day and just see if the headaches go away make a deal. If the headaches don't go away after 1 week on the medication, we're going to get you back to your provider and figure out what's going to, be the next medication that we try that might not have that effect. So anything you can do to sort of rejuvenate patients to take care of their diabetes, honestly, they have an old meter, see if they'll qualify for a new meter. It's a little piece of technology, but sometimes that little thing that's easier for them, new, will get them to test their blood sugar more than once a week. You know, see if there's something you can do. All the little things make a difference. It's very clear. And we kind of, I think the healthcare, just healthcare in general, sees it as a, you know, good diabetic, bad diabetic, even though the scope is so huge and nothing's good or bad. It's just one way gets you healthier and one way doesn't. And so staying positive about, well, what can we do this week? Maybe you're going to, you know, smoke only 10 cigarettes a day. Who knows what the tiny thing is that you'll do this week? So you're right. The burnout is terrible. See if you can find something that they think is interesting and latch onto that. We'll work, see if we can get you a new meter. We'll see if we can get you in this program that's going to get you veggies in your house to eat. Or, you know, see if you and your friend Betty can go for a walk twice this week. You know, little things make a huge difference. And so don't ask them to, you know, eat healthy as of today. Not going to happen, right? Little things. And
yeah, one of the comments in the chat is somebody who said, I have a member who now has a continuous glucose monitor, and it has greatly helped her in being more aware and compliant with her diabetes management. Seems that not having to do finger sticks was a big selling point for her.
yes.
So that's a good example of, you know, some new technology kind of inspired that member to, it was a good fit for her and really helped her be more compliant.
Absolutely. That is, you're completely correct. And what I talked about with, you know, the vascular problems, complications that we see with diabetes, it's directly related to how much time your blood sugar is high. So you can set alarms on the continuous glucose monitors to tell you when your blood sugar is high. Sometimes those get really annoying. And then you can address it. And so someone who's able to just look on their watch and see that their glucose needs to be addressed is going to have, you know, say, you know, right now, you know, if I was someone who only used a blood glucose meter to watch my blood sugars, I wouldn't be checking again for, you know, until I eat lunch, even if I was a great diabetic. But right now I can look at my wrist and see my blood sugar is 166. I don't need to do anything. But if my blood sugar said 400, I certainly would take insulin when I looked at it now, rather than not knowing about it until lunchtime. And so that's why every bit more information you can get about blood glucose is really important, because it's going to cause people usually to do an intervention to bring it down if they're on insulin. There's also a danger to overcorrecting, though, with continuous glucose monitors. There's something called insulin stacking. So even though it's just short-acting insulin in the pump, if they, you know, every hour are looking at the pump and last hour they gave the bolus, this hour it's still high and they're going to want to give the sliding scale insulin again, that can be really, really dangerous. Most of the pumps now, if you put in the high glucose a second time, will say, no, you already have insulin on board to cover that. It should be coming down over the next couple hours and it won't give you the insulin. But if someone's trying to do it manually, oh, my blood sugar is still 300, I'm going to take 10 more units. It gets very dangerous, insulin stacking, because then you'll go very low later. So there's a balance in there. Mm-hmm. But the more we can be aware of the high blood sugars, the more we can react to them, the better control will be over time. Those continuous glucose monitors are great. I saw some comments on the different types. The one that's, I try not to use too many brand names, but there's one that's available really at any drugstore, covered with a prescription, but it has the patch, and then the initial kit comes with the monitor thing that you swipe over it and it'll show you your blood sugar. So it's not as good as the ones that are on your wrist, but those cost a lot more. But this one, people will swipe and look at it much more frequently than they would poke their finger. Plus, when it's new, you want to look at it all the time. Ooh, this is what it is now.
Right.
So you're right. It can have a huge benefit.
Well, and it looks like, like one care coordinator here mentioned that with their ISNBC member, that for a particular brand, they went through the caddy waivers. So sometimes needing to be, if there's a particular electronic device in particular brand, sometimes needing to be creative, and there's different sources. So caddy waiver being one of them. Mm-hmm. So there's, let's see, is there any data on benefits of plant-based diets for people with diabetes?
The most compelling data on diets for people with diabetes really take into account carbohydrates. Now, we've known this for a long time, that your insulin needs are directly related to how much carbohydrates you eat. So when doing a diet, it's better to eat lower carbohydrate. There's not specific great data that says whether that's plant-based versus anything else. There are good studies that show that people who have type 2 diabetes, who do ketogenic diets, which are the very low carbohydrate, the high protein and fat diets, they actually do pretty well. But before you would recommend that to anyone with diabetes, you'd want them to check in with their doctor, because if they have any kidney issues, you don't want to do the protein load diets. So that's general helpfulness is reducing carbohydrates helps. That's what, it is the thinking that we have with diabetics about, don't eat sugar. Well, yeah, because that's a high carbohydrate thing. Now, people who have an insulin pump, all they have to do is be realistic and count carbohydrates and program that into their pump, and it'll give them the right insulin. So if they eat a piece of cake, as long as they count the carbohydrates and put it in, they'll get the insulin to cover it. But you do have the diabetics out there who feel so guilty when they eat the cake that they kind of want to ignore it. And they're like, yeah, I'll put in 30 grams when it was really, let's be honest, 90 grams of carb or whatever. Making sure that they're honest and counting everything that they eat, because also like Halloween candy, if you're eating one here and there during the whole night, your blood sugar is going up tiny bits all night, just take insulin for it. That's the solution. But if it's someone who's on oral medications, you do want to focus on moderate carbohydrate levels. But everybody has bad days. And we don't need to call them bad days. Everybody has days where your diet is not as ideal as you would hope. So yeah, we all have to live in the real world.
So I want to go back a little bit on the comments here, and somebody pointed out just the concerning numbers of Native Americans in Minnesota with diagnosis of diabetes, and it being kind of an alarming number. And is there anything specific being done to address the Native American community? And then before you speak to it, Jody, another person here, this is that sharing of information, pointed to that the tribes are doing pretty significant work, starting at the WIC level, to educate about diabetes and try to tackle that. So in addition to kind of all of that, do you have anything to add to that?
I have a lot of insight on diabetes in Native American communities. The best insight is that they're doing a good job themselves from within the Native American communities. In Minnesota, the different groups highly support groups that are doing positive things for diabetes, such as the American Diabetes Association. They donate large, generous amounts at different fundraisers they have directly from the tribe. We're lucky. Okay, so in Minnesota, this is another thing that's a unique thing in the community, is that we, one of our tribes that's so small, the Mdewakanton Sioux, have a casino. And so it's such a small tribe that the incomes are so high that they are very good at having lots of providers in there taking care of their members for diabetes. They get lots of buy-in from the community. They give large amounts of money to the people who are doing good things for diabetes, like the American Diabetes Association. So they are much more likely to be able to make a difference in their community. If you look out in, South Dakota has some very, very impoverished nations that can barely get their people housed. The Mdewakanton Sioux community, if you drive through it, if you know people there, they live in the cluster of houses there is mansion-like. They have a lot of money. If you go out to South Dakota, they don't have enough space to house people. So it's very, very highly different. And so in the places like our Mdewakanton Sioux here, they are very involved. They have leaders who are very deeply involved in this. In somewhere else, there's these impoverished communities who don't have the money to invest. They also have so much even more deadly things going on. People who can't be housed, people who don't have clothes or food, that they have to focus their energies in different places. And many of those rely much more on government help. So if you looked just at the uniqueness, when we talk about using a community advocate, in the Mdewakanton Sioux, you have these great advocates. They are so good. They're well-trained medical people who will go out and interact and get people really what they need, but in a cultural conversation, a culturally appropriate and a conversation. Whereas, an impoverished community that relies on a government-based medical center may have great providers. They might. Many times, though, those places can be staffed with people who, for example, for medical school have signed up to be part of the government corps of doctors to go to medical school, have their medical school paid for, and then they have an obligation of a certain number of years to work on a reservation. That can be great in people who are great people, but it can also feel like a trap to some people and can cause not as great engagement with the community. So what I'm just saying is that in places where there's money, especially the ones with casinos, which there's a lot of around the country, they generally have better care and better community outreach. But in every community, there is a really high recognition of how diabetes is affecting them. And so there's usually good community advocates wherever you go, but you just have to find the people to kind of work with. So it's a very unusual population.
Mm-hmm. So what you're saying, it kind of goes to that there's disparities even within subgroups, within mm-hmm. communities. So within the Native community, there's disparity between different tribes and different communities.
There's actually a significant difference even in the incidence of diabetes among different tribes, different places, which is very, very interesting. It's not just a general, Native American background. It's, they've done lots of studies on, even in, I think it's Arizona, there's one group, I'm not going to remember the names of them. It's a big group that has an incidence that's remarkably different than a very small tribe that lives in the center, that has a different genetic background, and they have a completely different incidence of diabetes, just genetically different. So there's no one good answer.
No, for sure. There's a couple of questions that tie together here about the use of referring people to a dietitian. And somebody here makes a good point about so often people are handed paperwork to try to explain their diets to them. It's hard for them to follow. There's sometimes can't read, or English is their second language. And so can you speak to that in terms of diabetes education and the value of dietitians or other professionals?
Very, very important. Very important part of the team. Now, just absolutely important. But the other thing that's really important with that is engaging community members and family members, because they can get great information. And it may be that the dietitian, while they were there, explained things really well to them, or maybe they didn't understand it, or maybe they forgot it. Then all they're left with is this written stuff that doesn't make sense, and it may not apply to what they eat. Okay, so our different people across Minnesota, across the US, eat very different things for dinner, right? So if you have something that says you should have, the piece of meat the size of a box of playing cards, there's so many people who aren't going to eat anything like that. That's not what they're, you should, and they'll say you should have that, and then this amount of mashed potatoes and this amount of vegetables on your plate. That's great, but you didn't even ask them what they eat to start with.
Right.
So that is where it's so important to pull in community. Someone who knows about how to cook healthy in the way that they cook can help them look at even someone who just knows how to cook healthy in their culture can help them look at the materials that they brought home and help try to fit how that can work for them. But you're right. And I'm just so encouraged by the program going forward from Minnesota Department of Health, where they'll be encouraging that kind of community involvement and community advocates and groups within the community so that they can talk about how do you cook healthy if you're cooking Thai food. I'm not sure how to make it healthier, but there's people out there who know that. And so that I'm really excited.
It speaks to that health disparities and health literacy as well. And that somebody makes a point here that often those people get tagged as being non-compliant when really they are not understanding and they're too embarrassed to ask, or they don't know who to ask. So ensuring that they understand and getting them resources. And that's something that as care coordinators, you might be able to tease out with a member in terms of asking the right questions to really, for you to understand if they really are understanding what the instructions are. And if they're not, to get them, the help, whether it's through a dietitian or an interpreter or a family member or somebody who can help interpret that information for them. Really important. So we are we have about 5 minutes to the hour. So we're getting really close to the end, but and so many good questions. It's so great to see such an engaged group.
I wanted to just add one more thing about diets. I noticed lots of questions about specific kinds of diets. So I would say this is another place where it's very important to support your members where they are. I wouldn't recommend a specific type of diet to anyone, and I would recommend a dietitian. There's things about, one of the latest comments I saw was the vegan diet. But again, decreasing carbohydrates is a good idea. And so talking with your doctor or with a dietitian is really, really, really important to find. I just want to make sure that people don't go out and tell your person who's never eating a good diet that they should be on a, any kind of specific, you should be on a vegan diet, you should be on an Atkins diet, you should be on a, Weight Watchers is more kind of flexible with what you eat. But just focusing really on what they eat now, how they can make a change to make it healthier.
Right.
And but not pushing them towards a specific type of diet without advice from their provider.
Right. So much to cover here. And again, there's more questions in the chat, but we don't really have time to address them specifically. But what I can say is that the questions that have been asked today are really going to help us in terms of framing up future trainings and some topics that clearly, come out in some of the questions being asked. So if you didn't get your question asked, watch for future trainings from our group, and hopefully over time, we can get you feeling like you really understand what some things that you can do with your members to improve their health and their diabetes care. So this final slide is a link to the evaluation. Please take a few minutes to click on that link, or you will be getting an email with that link as well. And you'll receive a certificate of participation after, once you complete the evaluation. So, and then the recording of this training will be posted on the Stratus Health website. And again, the link is provided in the PowerPoint that everybody received. I believe that was sent to everybody yesterday. So fill out your evaluations. We appreciate that. And we appreciate Dr. Jody Nelson and your presentation today. And I think I learned a lot, and I hope everybody else did as well. Nicole also put the evaluation link in the chat if anybody is still logged in and wants to click on the link in the chat box. Thank you, everybody. Thanks for everybody participating, everybody who logged in today. And again, thank you, Dr. Nelson, for your presentation. We appreciate it.